everybody. And at the outset, I would thank the entire team of DiaObecon and especially Dr. Bangsi Sabu for inviting me here, right from 1500 kilometers away from the eastern part of India to deliver a lecture on Imeglimin. So he had also requested each author to put some stories from the history of diabetes. Now history doesn't necessarily mean it will be 100 years old. So I'm just picking up a history just 10 years old, and I will tell you why this is important again. So this was a time in 2015 when empagliflozin had just come to the market, and with empiric study we were going gaga with the weight loss effects, etc. So the study was actually looking at the sugar on the brain circuit. Most of us know this, but maybe all of us should know it, and they should percolate to the patients as well, so that we can make them understand the problem of diabetes and diabesity, that is obesity plus diabetes. The story was such that scientists say they have identified a specific neural circuit in mice that can increase the compulsive overeating of sweets but doesn't interfere with normal eating patterns necessary for survival. That is exactly the reason why in Indian culture as well as Western cultures as well, sweets and desserts are served at the end of the meal. If you take it previously, the problem are twofold. Number one, it decreases the normal appetite for you to take a balanced diet, and number two, it will override the brain circuits which actually make you feel full. So the satiety center will be overridden or overridden, and you will take more sugars. That is exactly what we call sugar craving in today's time. So we basically know this. Now why I'm saying this? So turning this set of neurons drove the mice to seek the reward of a sugary drink even in the face of a punishment. That means they were put in a cage, a sugary drink was kept there, and an electric shock mechanism was given to their feet as soon as they took the drink. So they went on taking the drink despite the fact that they were given electric shocks. That's exactly what happens to humans as well. That means if you are given an incentive, you are even preferring that despite the fact you are getting a punishment for the incentive. That is important, especially in today's world where pediatric obesity, just in last week in Times of India there was a big article that about 25 to 30% of the population of children in tier 3 cities were having pediatric obesity. So the next 10 to 20 years we will be dealing more with such cases of diabetes, because these pediatric population will move into the adult population, leading to just the diabetic control becoming haywire. So this part has to be understood. So when the researchers shut down this pathway, the compulsive sucrose seeking decreased. So why this history is important, why I'm saying this? This is because can we now focus our research on this segment? We need to do that. And can we now talk of drugs that can suppress this pathway specifically? That should be the focus of attention or region of interest for all of us who are dealing with diabetes. So this should be a food for thought in a world of diabetes. So now coming back to the topic on imeglimin, we all know this about the pathophysiologic summary of type 2 diabetes. We basically traditionally understand that there are two problems here. One is insulin secretion issue, one is the insulin action issue, that is a post-receptor defect of insulin resistance. Now suppose you have 100 workers in your factory which you are running. 30 people go on a strike. So the entire work comes on the rest of the 70 people. So ultimately they will be overloaded. That exactly happens with type 2 diabetes. So beta cells shut down and the rest of the work goes to the rest of the beta cells which are taking care of it. So ultimately there is a beta cell overdrive leading to their dysfunction and loss. So ultimately what happens, the powerhouse of the cell is actually the mitochondria. We all have talked about endoplasmic reticulum stress. Now it's time to talk about mitochondrial stress as well. So mitochondrial dysfunction drives oxidative stress and inflammation, aggravating the insulin resistance and beta cell failure. I was just doing a PubMed research on this particular phrase, mitochondrial dysfunction in diabetes. So ultimately what I found, there were about 10,907 results which came up as on yesterday evening's date. That means there is a lot of noise in the market now about mitochondrial dysfunction. And look at the left side of the panel, if I have this pointer right, here you can see how temporal profile of the searches have increased over a period of time, and they are projected in 2026 because some articles are in publication, they are also put here. 3 months only left for this year to turn around. So this is how the interest is rising on mitochondrial diseases, mitochondrial dysfunction, and how we can address those things. So coming to this busy slide, I will just tell you about how the causes lead to the effects, and we see that if you see the bottom of the slide, that the glucotoxicity that we talk about, that means a lot of sugars around the pancreas which is not enabling the pancreas to release its normal quota of insulin, and also lipotoxicity. If your triglyceride, it was a discussion going on in the last session, if it's very high, if it's a lipid rich serum, that also creates a disturbance in the beta cells function to release insulin. So all these things, as well as environmental factors, the mutations, the risk alleles, etc., ultimately leads to a cascading effect. If you look at the effect on the upper side, so this leads to cellular injury, antioxidant capacity is decreased, so beta cell mass will ultimately suffer. And if you look at the right corner in the middle part, ETC, that is the most important thing which we will discuss today. This is basically electron transport chain. So we read this in physiology and biochemistry classes when we were doing MBBS. I'll just take you down through that lane as well. If you look at this picture, there is a GIF which looks like something like a cosmic interstellar event, but basically this is the electron transport chain which is occurring, and from the left side these are complex 1 to complex 5. So this is where we are focusing. The complex is somewhere over here. This membrane is actually functioning, and this is why we are all alive. We take glucose from the surroundings, we take oxygen from the atmosphere, we undergo cellular oxidation, ultimately release ATP, and that actually enables us to function all the functions of life. So this is what actually happens. These are the enzymes which are happening, and they continuously push up protons on the other side of the membrane, and this proton ultimately will be utilized in the last step where ATP will be generated. So this is the most important step which we should talk about in diabetes management now. So this summarizes the entire thing of imeglimin and metformin. Many people ask that metformin and imeglimin almost belong to the same group, but no, if you look at the classification of drugs, imeglimin is put in other anti-hyperglycemic agents, whereas metformin is a biguanide. So what really happens is, this is the structure. If you look, all the structures are transmembrane, but this one falls short. So what 1, 3 and 4 do, they actually push up protons upwards, which this one cannot do. Now what is happening here is, metformin inhibits directly complex 1, and this is a non-competitive inhibition. So again, taking back to biochemistry classes, non-competitive means once you inhibit, even if it is moving away from the receptor, the inhibition would sustain. Whereas imeglimin causes competitive inhibition, and it binds at this site, whereas metformin binds at this site. So sites are different, actions are different, consequences are different. This part has to be understood. And what happens to this one? Imeglimin rebalances and refocuses and maintains this channel. So again, coming to a factory model, that means we have 3 workers working. Metformin will shut down one, because you are paying for 3 workers getting the same work. Metformin shuts down this one, imeglimin reinforces this one. So it shuts here like metformin, but opens up this one. So the same work is done. So what is the benefit of this? The reactive oxygen species, or the reactive oxygen metabolites, are actually decreased. So the oxidative damage also comes down. Now, we all understand about the limitations in the current therapies in type 2 diabetes. If you look at any guideline, do you really see anywhere talking about mitochondrial dysfunction? Yet not. So we all talk about certain drugs which are specific mechanism of action, and if you look at the algorithms given by ADA, AAC or RSSDI or any guideline, Canadian guidelines, Australian guidelines, you see that they are classifying drugs according to their chemical mechanism of action and what problem does the patient have. Does the patient have ACVD, heart failure, CKD, weight issues, cost issues, etc., and then you give the prescription. So need of the hour will be something which has an action on insulin secretion and insulin resistance. It will reduce, like metformin, hepatic glucose production, peripheral glucose uptake will be increased, which obviously, as Dr. Makar was saying, that the peripheral utilization is very important to clear up the sugars that you have built up in your system, and reduces beta cell apoptosis, and lastly correcting the mitochondrial dysfunction. This part is actually missing. So this drug definitely has a differentiated mechanism of action, and it was approved in Japan in 2021 and in India in 2022. So pharmacological properties, I will just brush through it very quickly that I have already mentioned. There is reduction in the reactive oxygen species being generated. In the organ, protective effects are there. These are human endothelial cells. So there have been studies preclinical on endothelial cells, and flow mediated dilatation. These are some studies which the researchers do, and they have shown that endothelial dysfunction is improved. And lastly, insulin secretion is increased. There is another difference with metformin as well. Do you actually target PP sugars with metformin? Usually don't do, because it tends to control the fasting sugars, because HGP, that is hepatic glucose production, is decreased. But here GSIS, that means glucose stimulated insulin secretion, that is also increased with imeglimin. So you are actually controlling all sides, all facets of the glycemic triad with this molecule. So pharmacokinetic profile, what we need to understand is important, that it has low plasma protein binding. That means you ingest the drug, it goes into your space, and then it goes into organs as well. If it was highly plasma protein bound, it would have remained in the circulation and not penetrated into the organs. This part is important. And also it is insensitive to ethnicity and food intake, though traditionally we give after food, but actually the researchers have found that it doesn't interfere with food intake. So this distinction, this entire slide I've already talked about as I was going through the slides. Many people ask, do you have any CV efficacy? Obviously this part is important. So 3 points I have to mention here. In heart failure studies, they have been found to be safe. QT prolongation has not been found, but dedicated CVOTs are not there. This may be because of the peculiarity of situation that they are not planning to use it in the US market or the European Medical Agency, etc. So we don't have CVOTs till now. Question of lactic acidosis. Many people ask this because metformin is known more theoretically, because in my last 15 years of practice I have never seen a single case of lactic acidosis, and so maybe you have also not seen. And as the mechanism of action has been shown, that both imeglimin and metformin promote anaerobic environment. So there may be potentiality of causing lactic acidosis, but as I showed, they reinforce the complex 3. That is the reason why lactic acidosis is told to be even lesser than metformin. So metformin I have never seen, so maybe in my whole lifetime imeglimin also will not cause any lactic acidosis. Advantage for kidney, obviously there are 2 things here. Researchers have shown many things regarding this, that a dose reduction may be required, which is written in this blue box, that according to EGFR you grade just as in metformin, but there is one line warning here that DCGI has given clearance in India to use until age EGFR of 45. So we cannot experiment below 45. If you do, you have to save your own skin if you are dragged to court. So till 45 it is allowed in India. So these were the major trials. I will not go into the nitty-gritties. Only thing to tell is times 1 was monotherapy, times 2 was with oral agents, times 3 was with insulin, and this is how the HbA1c reduction was noted in the studies. There are a lot of meta-analysis here, and they were doing many dose-finding trials, that how much dose should be used. We use at 1 gram BD, that is the standard dose, but there are studies with 1500 BD, even 2 gram BD. Some people ask whether we can use with metformin. Yes, there are 2 sets of trials which show that metformin was background use of 2 grams per day, as we use in all patients, provided CKD is not there. Over and above that, 2 minutes. Over and above that, there are studies to show that imeglimin can be used to a dose of 1 gram BD. There have been reduction with fasting sugars, as I already mentioned, because it overlaps in its mechanism of action with metformin, and also there is reduction of PP sugars because of the GSIS effect, glucose stimulated insulin secretion effect. These are the snapshot of systemic reviews done in our country, and many of those authors are already a part of this conference as well. So there were other things like CGM was also applied to understand the pattern, how the variability is varying, and this is what happens. You can see a little bit of smoothening of the effects which we see at the end of the study. So if we prolong the study and we can follow this up for a longer period of time, maybe we can generate good data, and this is one place which we can all employ in our clinical practice. So we can also publish our own data on this. So this was the last thing we will tell about. The Indy Times trial was done about 8,000 odd patients in India in 190 sites, and this was done over a period of 3 months, and baseline HbA1c is taken about 7.9. the prescription pattern was 25% on monotherapy, about 70% on dual therapy, and 30% those patients who are on multiple drug therapy, they were also given. So outcome, they were looking at the HbA1c reduction and fasting PP etc. reduction, always showing salutary benefits. 45% of patients received achieved HbA1c less than 7, and you can see the difference in the graphs in all the aspects of monotherapy, dual therapy as well as multiple therapy. And serum creatinine was shown to be improved in some segment of that. We still do not know the mechanism how it happens, but this is common. Lastly, we are coming to the side effects. It is lesser than metformin. It can cause GI side effects, but in metformin intolerant patients as well, this is the consensus given by some of our KOLs, key opinion leaders, and there they told that we can use this in certain situations where there is metformin intolerance, where the patients are treatment naive, as well as in conjunction with oral therapy as well as insulin. Thank you.